affected with dementia. But the sad and interesting point is more than 70% of the care hours are provided by the women. So it's a time we have to think of starting many dementia care centers like de-addiction centers. So I call upon Dr. Sridhar Vaitheswaran, who is Assistant Director and Consultant Psychiatrist, Dementia Care, SCORF, Chennai. He is interested in applied research in dementia and geriatric mental health in low and middle income countries, and also an inpatient facility for the elderly with mental illness, including dementia. Now,
thank you very much. I thank the organizers for inviting me to talk on this very dear topic to me, and the chairs for the kind introduction. So I'm going to talk about my experience setting up a dementia care center in Chennai. And this is something which I have learned all as I started doing it and I went along doing it. So I'm just going to share my experience. I mean, some of it worked very well, some of it didn't work very well, and I had to learn on the job. So it's just a sharing of my experience. In no way I'm an expert in setting up or starting new services. I'm just sharing my experience here. So the first question is, again, as said by the chairperson, why should we have special centers for dementia? Why is it, or how is it different from other conditions like schizophrenia or other things? And then I'll also plan to cover what are the requirements when we plan to start a center, what are the things that we need to put in place, and what has been our overall experience. So starting with the dementia prevalence, all of us know that there is a growing prevalence of dementia in the country, across the world, particularly in countries like ours. And as you can see, that we see an increasing prevalence. And right now we have, again, this data is a bit old, and there is more recent evidence to show that the numbers are much higher than predicted. And this is something which I would definitely encourage the postgraduates to have a look at from the LASI study from India, and looking at the prevalence of dementia across various parts of India. And what is surprising is that they found that prevalence of dementia is much higher in rural areas than in the urban cities. So again, there's a lot of data here which will be very useful to plan services in the near future. If you think of just setting up dementia centers in urban centers like Chennai or Madurai or places like that, you also need to think about setting up dementia centers in rural areas. Of course, the requirements are slightly different. How you set up is going to be, again, quite different, but that needs to happen in the going as we go forward. So why should you have special dementia centers? So what's different about them? First thing is that we are seeing more people with dementia. I mean, all of you kind of doing general psychiatric practice, you will see more older people coming into your clinic every day. So that's a pattern, that's a trend that we are seeing. And often when they present to us as psychiatrists, they come to us in a crisis. They come to us with severe behavioral problems, extreme agitation, disinhibition, and things like that, which again it's a crisis, and the families are not able to cope very well with that, and hospitals can't manage, or a general hospital cannot manage such a patient. So as I said, regular hospitals, regular wards cannot manage a severely agitated person with dementia. And managing a person with dementia who is very agitated requires a lot of special skills which need to be developed. These are not, it's not a rocket science. That's applying common sense, and having some basic skills will really help manage these persons better. And again, the treatment goals for looking after managing a person with dementia is slightly different from a treatment goal of treating someone with depression. So again, this is very important to keep in mind as we are approaching a person with depression. So going forward, what are the requirements? The first and foremost is leadership. I think you need to have a good leader to kind of take or manage a good dementia center. Finances obviously are extremely important. If you don't have the money, you don't have the resources, Setting up a dementia care center is going to be very difficult, very challenging. The third important thing is the location, where you're going to place the dementia care center and how it's going to be funded and where it's going to be located. And of course, there's a lot of legal and permissions and licenses that need to be acquired. You need to think a lot about staffing, what challenges we faced. I'll be sharing that. And the most important bit is how a dementia center is going to be different from a general psychiatric center or a general hospital center. And again, the work culture and how the whole team and dementia, for that matter, many psychiatric conditions are very difficult to manage as a single person. So you need to have a collaborative approach in managing persons with dementia, and it becomes very obvious when you're looking after someone with dementia. So starting with leadership, you all know that. I don't have to spend a lot of time doing this. You're all leaders in your own way, having done what you have done so far in your careers. So you need to have a clear vision, a clear goal, a sense of purpose of where we are going, what we are doing, and how we are going to achieve that. And you need to actually motivate others, because especially when you're starting something new like a dementia center, there'll be a lot of pessimism. When I started having discussions about setting up a dementia care center, I faced a lot of pessimism, a lot of, எதுக்கு இதெல்லாம் பண்றீங்க, general psychiatry clinic ஆரம்பிச்சீங்கன்னா it'll be better. I received a lot of advice on that. So it's about motivating others, pulling through, problem solve. There are lots of problems we will face along the way when you are looking after someone with dementia, particularly when it comes to staffing and the burnout and all that. We'll talk about that a little later, and how you solve those problems as we go forward. And most important advice for all budding psychiatrists, I would say, is have a mentor. Choose a mentor who can help you, who can support you through difficult times. I was very lucky to have mentors like Dr. Tara, Dr. Padma, who actually helped me to push through some of the difficult times. So having a mentor is so important. So finances, again, I won't talk a lot about this. I'm not an expert in finances, but what I learned is that you need to have a clear financial model. So what model are you going to operate? You're going to operate a for-profit, not-for-profit. What's your income, where you're going to source your money from, and how much you're going to spend on a day-to-day basis looking after a person with dementia. So what is the cost to run a hospital? And all those things you need to really think clearly very lot about it, so that you can plan ahead. So how many beds are you going to have? Okay, so what is the number of beds that you're going to have for you to break even? So you're not going to run on a loss. If you're going to start running on a loss, the hospital is not going to function, you're not going to help people. So you really need to think about what is the bottom line there. And again, anticipate challenges. You need to actually look at what financial challenges you're going to anticipate, especially at times when there is a financial crisis, or when the number of occupancy is coming low. What are we going to do about paying salaries for staff? And again, staff, I'll mention in a while. I'll keep coming back to this again and again. Staffing is crucial. You can't afford to lose staff, especially good ones. Location. I mean, everything is important, but location is extremely important. If you're going to place a center very far away from, say, access to public transport, then it becomes a huge problem for staff to come and go. So especially if you're going to have a shift of people moving away, so evening shift முடிச்சிட்டு night வீட்டுக்கு போறவங்க ரொம்ப தள்ளி இருந்ததுன்னா, especially when there are women working in the ward, they will find it extremely difficult to get home and come back. So that will actually reduce staff wanting to work in the center. So think about all this. Of course, it has to be you can't have a very cramped setting. So it needs to be reasonably spacious. It needs to be located at a convenient place, and it has to have access to public transport. So these are things which you need to think about when you're planning ahead. Again, these are, again, I'm not going to spend too much time on this. This is our experience. This is all the things that you need to do before you set up a dementia inpatient care facility. Looking at, again, with the Mental Health Care Act now available, you need to think about all the processes and things that you need to set in place. And these are the various licenses you need to obtain from the local municipality, from the Pollution Control Board, and so on and so forth. Again, this is important. This we learned, நாங்கள் இதை பண்ண விட்டுட்டோம் ஆரம்பத்தில், death registration. And this is something which actually bit very hard on us when a patient passed away, and kind of getting the certificate, death certificate, was big issue for us. So think about it when you're planning. Staffing, again, you need to have a set of clinical staff, you need to have a set of non-clinical staff. I can't emphasize more on the importance of administrator and accountant. You need to have a good receptionist who is very affable, knows interpersonal skills, because they are your first point of contact. When the caregivers call the receptionist in a distress, அவங்க எரிஞ்சி பேசினாங்கன்னா அவ்வளோதான், அதுக்கப்புறம் பேஷண்ட்ஸ் வரமாட்டாங்க. So you need to have a good receptionist, you need to have a good administrator who can manage all these people and do your work. Again, coming to clinical staff, we all know that you need a good set of psychiatrists. You need to have good physicians, geriatricians, neurologists who are available on call, who can come. And for some patients, I hardly use a neurologist for assessing my patients, but sometimes I use when I have difficulty in diagnosing some patients or difficulty managing comorbidities. So in such patients, I may have to get the services of a neurologist. Often I get a geriatrician or a physician, and sometimes I get an orthopedician to come in. So you need, depending on the need, you may want to have a network of physicians and surgeons who can come and help you. Conditions like having a pressure sore which is not healing, or when someone has a severe diabetes and having a lot of end organ failure, how are you going to manage that? So often people with dementia have multiple comorbidities. So you need to have a good network of physicians, and you need to have a high threshold for managing some of the physical problems. So you can't say எங்களோட psychiatric hospital தான் உங்களுக்கு வந்து heart problem இருக்கு நாங்க admit பண்ண மாட்டோம். Actually the challenge is a patient with severe heart problem and dementia cannot be managed in a cardiologic facility. So you need to have a little bit of flexibility and a higher threshold for admitting patients with physical health problems. So you need to have trained nurses, a physician who can come and advise you on how to manage these patients. And I have to say, in the last 4 years, I've learned a lot more about physical medicine along with geriatric psychiatry as we went along. Again, nurses and nurse assistants, they are the backbone of running a good dementia care facility. You need to have other people like physiotherapists, psychologists, a good dietitian, a good social worker. If you're lucky, if you can get an occupational therapist, they will definitely add value, but I have really struggled to get a good occupational therapist to work in our setting. Now, the most important bit, again, I'm going to say this for each slide, because each of these factors are important. I can't rate one above the other, but all these things come together when you're going to set up a good dementia service. So design for dementia. Design and environment are extremely important, because that's what sets apart a good dementia center from a run-of-the-mill psychiatric care center. Why should we think about design for dementia? There are multiple reasons. One is the neurodegenerative process per se. So people have multiple cognitive impairments. They get disoriented very easily. They can't locate the toilet. You can tell them once, but then they forget. And they get topographical disorientation. So when they are in the bedroom, from their bed to the toilet, so the access has to be very clear, and it has to be visually available to them when they can see that the toilet is right ahead. இல்லைனா உங்களுக்கு நிறைய பேர் என்ன ஆகுனா, the main complaint is they are urinating inappropriately, they are defecating inappropriately in complaints இருக்கும். So cupboard திறந்து அதுக்குள்ள urine போயிடுறாங்க அப்படிம்பாங்க. The reason is the door of a cupboard, if it looks very similar to the door of the toilet, the person often gets very confused. So it's very important you actually have a clear design model in which the toilets are differentiated from cupboards. Again, we will talk about that in a while. Now, neurodegeneration, the primary pathology in dementia, causes a lot of problems in helping the patient orient himself or herself to the situation. So for that reason, we need to have a good design principle. The other important bit is sensory impairment. Many older persons with dementia, they also have vision impairment, they also have hearing impairment. So you need to have an environment that is friendly to help these people. Again, there is lots of physical health problems. They will have mobility issues. They can't get up fast, especially if you're looking after someone with Parkinson's disease. Their mobility becomes very limited. Or if they have arthritis, they need help to move to the toilet. So, நீங்க toilet ரொம்ப தள்ளி வச்சுக்க முடியாது. There can't be steps and things between the patient's room and the toilet, and the access has to be very easy. So those kind of things play an important role. And then, of course, when a person is very, very agitated and restless, aggressive, you need to have a space that can contain them, that can actually give them an opportunity not to be contained in a very cramped space. So you need to have a space that gives them that freedom to move, but that doesn't put them in danger of harming others or harming themselves. So all these things are important, why we need to have a good design for dementia. So the basic principles are the person with dementia has to maintain independence. At the same time, well, we want to minimize the risks. So we want to make them do as much by themselves. So again, this is a question I ask many of the nurses when they first come for the job or when the nursing assistants are being trained. I'll ask you all of this. When you're passing motion in the toilet, how would you feel if someone stands next to you? Okay? How many of us have done that? It's extremely difficult to do that. Okay? And many elders are expected to pass motion with a person standing next to them. Illa bedliye neenga ponga naanga bed pan vekkrolla bedliye urine ponga bedliye motion ponga nu solluvaanga. But it's very difficult for them to do that. Putting ourselves in that situation, it's extremely difficult. So we need to actually encourage these patients to use the toilet, but we need to make it easier for them while minimizing the risk of falling. We are worried about them falling, slipping in the toilet and all that. So how can you minimize the risk but maintain their independence, maintain their dignity to a larger extent? So that's one of the main principles for design for dementia. And manage the risk very unobtrusively. You don't want to put a barrier. நிறைய பேர் என்ன பண்ணுவாங்கன்னா ஒரு கேட் போட்டு விட்டுருவாங்க. So patient வந்து கேட் கதவு கிட்ட means something is a very common complaint when patients come for admission. வாச கதவு போய் அடிச்சிட்டே இருக்காங்க. கேட்டுக்கு குலுக்கிக்கிட்டே இருக்காங்க. சத்தம் போடுறாங்க. கேட் மேலே ஏறி குதிக்க பார்க்குறாங்க. Again, there is a barrier. The common scenario is a person with dementia still thinks he or she is 30 years old or 40 years old. They have to go to the school to collect their children from school. Okay? They forget that they are 80 plus and their children are all grown up and they have grandchildren. Adha marandruvaanga. They still think they are 30. They have to go to school and pick up their children. Mani moonachu and velila vida maatengringa. So they want to go out. Okay? And you are actually stopping them from going out, which causes a lot of distress in them, which causes a lot of behavioral problems. So managing these patients, you have to manage the risk very unobtrusively. You kind of hide away certain things. The door has to be in such a way that it is not very obvious. Okay, when you want certain doors to be very obvious, like the toilet doors, when you want certain doors not to be very obvious, you don't want an obvious lock to be seen in front of them. So நீங்க டாய்லெட்ல வந்து you can have a two-way lock. ஸோ வெளியிலேருந்து திறக்கிற மாதிரி நீங்கள் வச்சுட்டிங்கன்னா நிறைய பேர் என்ன சொல்லுவாங்கன்னா டாய்லெட்டுக்குள்ளே போய் விழுந்துடுறாங்க, அதனால் கதவை தாப்பா போடாதீங்கன்னு சொல்கிறோம். அண்ட் தட் பிகம்ஸ் அ பிக் இஷ்யூ ஃபார் தம், இஷ்யூ ஃபார் த ஃபேமிலி மெம்பர், இஷ்யூ ஃபார் த பர்சன் வித் dementia. டாய்லெட்டுக்குள்ளே போக மாட்டேங்கிறாங்க, ஒத்துக்க மாட்டேங்கிறாங்க, டாய்லெட் கதவை சாத்தாதீங்கன்னா கேட்க மாட்டேங்கிறாங்க. ஸோ த சிம்பிள் திங் இஸ் ஹாவ் அ two-way lock. ஸோ யூ கேன் ஓப்பன் த லாக் ஃப்ரம் அவுட் சைட் டூ. ஸோ இட்ஸ் ஈஸியர் தட் வே. Keep things very simple, keep things very familiar to the person. Again, we'll talk about that as we go forward. Reduce unhelpful stimulation. Romba sattama irukku, too many distractions going on. Reduce all that while you increase helpful things that keep the temperature right, keep the ambient noise right. Encourage movement, encourage engagement. So நீங்கள் ரொம்ப கிராம்ப்டாக ஒரு ஸ்பேஸில் வச்சிங்க or keeping them very isolated for a long period of time, that reduces the level of engagement. So how you encourage all that, it's extremely important. And also provide opportunities. Sometimes all of us feel like I don't want to be in a group, I just want to go sit alone for some time. Okay, I'm very stressed, I just want to sit alone for some time. Give them the opportunity to do that, so they can go and sit alone, but again encourage them to come back when they feel like coming back to the group. So again, going through the design, some of the basic principles. Lighting, you need to have good daylight through the windows. You can't have a very dark room, particularly during the daytimes. You need to have a lot of daylight. You need to have bright enough lights, but not too bright, but bright enough lights. Again, there are lots of recommendations on how much luminosity should be there for people with dementia, especially when they have vision impairment, how much of luminosity should be there. Adala nariya advice irukku. There are lots of websites. In fact, design for dementia is a new architectural topic. Many architecture students actually take it up as a project. So design for dementia, particularly lighting, is very important. And prevent dark areas. Often people with dementia confuse when there are shadows, when there are darker parts of the room, they confuse that with something being there or someone being there, and they feel threatened by that. So avoid all that. Sometimes people with dementia, they refuse to enter the toilet, and that's because the toilet is very dark and unilluminated. So it's not, the lighting is not adequate, it's very cluttered, lots of buckets. Again, common complaint is avanga toilet la poi commode la urine pogama bucket la poidraanga. And the problem is they're cognitively so impaired, their neurodegeneration has made it confusing for them to differentiate between a commode and a bucket. So remove unhelpful things, remove the bucket, just leave the commode in the toilet. So keep it simple for them. And avoid reflective glare. நிறைய வீட்டில் என்ன பண்ணுவாங்கன்னா கண்ணாடி வச்சுட்டு கண்ணாடிக்கு முன்னாடி பேசிகிட்டு இருக்காங்க, கண்ணாடியில் யாரோ இருக்காங்கன்னு நினச்சி பேசிகிட்டு இருக்காங்க அப்படிம்பாங்க. ஸோ ஒன் ஆஃப் த திங்ஸ் வி அட்வைஸ் இஸ் அவாய்ட் ரிஃப்ளெக்டிவ் சர்ஃபேசஸ், ரிமூவ் the windows, or if you can put a blind, cover the window with a blind and use பண்ணும்போது எடுத்துக்கோங்க, மிச்ச நேரத்தில் just keep it closed. Even TV screens, when there is a reflective TV screen, persons with dementia often talk to that. So again, avoiding all these things will prevent a lot of problems from happening. Flooring, keep it very simple, keep it non-reflective, non-slippery. Shiny floors, sometimes they'll think that there is water in it, they avoid walking on it, or they feel that they're going to fall. Speckles, patterns, particularly mosaic floors, or when there are tiles with multiple patterns on them, people misinterpret them as, animals or insects on the floor, and that can cause problems. Again, the color of the wall, there should be clear demarcation between the color of the wall and the color of the floor, so that they know where the floor ends and the wall begins. So because of visual impairment, you need to be very careful about how you do that. And similar for edges of the stairs. So when there is a raised level, they need to be clear. There has to be clear indication that there is a raised level. So contrasting colors will often help in these situations. The bedroom, again, keeping it simple. Don't use patterned bed sheets. Okay, when there is a design on the bed sheet, when you have flowers and things like that, again, they can cause a lot of confusion. So keep them plain. You can keep it in white, or if you want to keep it in some other color, but keep it plain. Don't use any designs on them. And remove clutter, remove unnecessary stuff from the bedrooms, from wherever they are. And you can have a labeled storage. So you can have cupboards. Again, I'll show a few more pictures. These are all from our inpatient ward. So if you have a wardrobe that is dedicated for the patient with dementia, or when you have a toilet door, again, having clear labels help orient them. And lighting, of course, we have already talked about. So these are the important things to how you, when you're thinking about designing your toilet, unobstructed sight lines from their bed. So அவங்க எழுந்தாங்கன்னா டைரக்டா toilet should be in their line of vision, okay? And clearly labeled. They should know all the toilet doors in our facility are yellow in color. So it's the pattern. Yellow is a toilet. So from wherever they are, they'll be able to see a yellow door. And again, there are signs on these toilets. And convert to handheld shower, so it's easy to give bath to someone who is in a wheelchair. Remove the mirrors, as I've already said. Handrails to prevent falls, and you can see handrails which can be raised and lowered as and when necessary. And using taps that are very simple. Again, modern toilets, they have complicated tap system, especially in the hotels. There are complicated taps. So either one taranda venir varum, one taranda pachthani varum, one taranda mele endu kottum, kizha kottum. All these things cause a lot of confusion in people with dementia. Keep it very simple. Just keep one tap, okay? And the traditional design la thirupi moodra mari vechingna, it's very simple, very straightforward for them to use. Again, activities and dining. Again, the furniture has to be simple. Better to keep it, hard. Don't use too many cushion stuff, and keep it very traditional that they are used to, and having appropriate levels of stimulation, avoiding, too many interruptions. If you're running a day activity, and when there are too many people coming and going from that area, it can cause a lot of distractions. So when you design in such a way that when you're having a day activity, the patients are not disturbed too much by too much other things going on. Administrative people walking and coming through, new admission, vandittu poranga. All those things you can avoid when you actually have a design it in such a way that's away from all that hustle and bustle. So good acoustic environment, which is very calm, very safe for them to, and very predictable, not too many noises. Didini yaro and the loudspeaker podranga, paattu podranga, all those things. Comfortable room temperature. Again, access to outdoor spaces. You can't keep people with dementia always in indoor settings. You need to have access to outdoor spaces. So this is our rooftop garden. Again, space sometimes becomes very premium in a city. So you need to think about how much of an outdoor space you're going to give. So if you have, ideal is to have it on a ground level, have access to a garden, a lawn and things like that. But if you can't, then think about having a rooftop open area. The last but not the least important part is having a shared work culture. So it's about managing a person with dementia is a team effort. So every person contributes equally in managing a person with dementia. So a nurse's opinion, a physiotherapist's input is as much valuable as a doctor's. So kind of make them feel part of the team. It's about rethinking dementia. Dementia often gives a lot of negative vibe to people. So dementia பார்த்தாலே எனக்கு வந்து டிப்ரெஷனாக இருக்குது, அதை கேட்டாலே எனக்கு கஷ்டமாக இருக்குது, அது எப்படி மேனேஜ் பண்ண போகிறோம்னு தெரியல, what is the point in treating someone with dementia? So those are the kind of negative things that you often hear. But it's about building on the strengths and abilities. Even people with moderate to severe degrees of dementia can do certain things. You'll be surprised when you actually engage them in activities and make them do things. They'll be able to do a lot of things that they were doing before. If you give them the right environment with the right kind of support, we can actually make them feel safe. They can feel better. So building on the strengths and abilities of each person with dementia, identifying the strengths, identifying that we had a gentleman with moderate to severe dementia who was very good in singing. So when actually given, but he had significant difficulty in talking. But when you actually play songs, பழைய தமிழ் பாட்டு, பழைய ஹிந்தி பாட்டுலாம் போட்டால் he will start actually singing and he can play a mouth organ very well. So giving that to him actually calms him down and reduces this behavioral problems in many of these patients. So optimize their quality of life, optimize their independence as much as possible, and delivering a very person-centered care. So identifying what their needs are, what their interests are, and catering to that. So you can't have, again, a common mistake done in many daycare centers or dementia care centers. எல்லாருக்கும் காலையில் நாங்கள் பெயிண்டிங் கொடுக்குறோம் சார், எல்லாருக்கும் நாங்கள் வந்து drawing கொடுக்குறோம் அப்படிம்பாங்க. So not many people will actually like painting and drawing. Actually, if I were to develop dementia and if I were to be admitted to a setting like this, அவங்க எங்கிட்ட பெயிண்டிங் ஏதாவது கொடுத்தாங்கன்னா திருப்பி அவங்க மூஞ்சிலே தூக்கிடுவேன். Okay, so it's not what I want. Okay, I am interested in something else. Identify that and give that to me, so I'll be engaged better. Okay, it's about a shared vision of hope for each person with dementia. So that's very important, and that has to be instilled into the work culture. So all of us are singing from the same hymn sheet, and we're all kind of delivering the same thing for the person with dementia. So our experience in the last 2 years, we started our center in September 2021, and till August 2023, this was the last time I actually collated all the data and looked at it more carefully. We are still continuing the data collection. So we had 165 admissions over 2 years. Of whom 116 had dementia. 70% of the patients admitted to our ward had dementia. Other conditions like psychosis, we also take in patients with psychosis. We take in patients with depression. We have had one person with alcohol use problems. So often the reason for admission is dementia. And some patients were readmitted a few times. We discharged them and then they came back again. Overall, we had 90 index cases of admission of dementia during the 2-year period. The mean age, as you can see, is quite high, 75. And the mean duration of stay is 31 days. Again, this is something which we were cautioned a lot when we started talking about dementia. நீங்கள் அட்மிட் பண்ணிங்கன்னா அவங்க டிஸ்சார்ஜே பண்ண முடியாது, அவங்க வந்து அங்கே தான் இருப்பாங்க. நீங்கள் ஆரம்பிச்சிங்கன்னா it's going to be a big drain on your resources. Nobody is going to pay for it. Nobody is going to, wanting to take the patient back home. So those are all myths. Actually, we found that we are able to discharge people with dementia back home. And this is exclusively for people with dementia. I'm not including depression and psychosis data here. Okay? So exclusively for people with dementia, we're able to actually discharge them. Of course, some patients stay, as you can look at the standard deviation, some patients stay for a longer period of time depending on their on the problems. Some behavioral problems are very difficult to manage. We have a gentleman who is sexually very disinhibited, and especially towards the grandchildren at home. So this is a patient who we continue to have in the ward for a very long period of time because we are not able to mitigate the risk at all in this patient. But most of the patients, in fact, more than 80%, as you will see, were able to go home. And again, there's an equal distribution of men to women in our inpatient facility. And common reasons for admission were agitation, sleep disturbance, hallucinations, aggression, and reduced food intake. And this is something which we see in people with more advanced dementia. அவங்க சாப்பாடு கொடுத்தா எடுத்துக்க மாட்டேங்கிறாங்க, துப்புறாங்க, and that's something which we see a lot. Again, that's a reasons for admission and managing is a separate topic on its own. We'll probably talk about that a little later. So what are the types of dementia? Again, the most common was Alzheimer's disease. The next was mixed Alzheimer's and vascular disease. And then, of course, we had a lot of vascular. And FTD was surprisingly more than DLB, even though we see more dementia and Lewy body disease in the clinic than the frontotemporal dementia. But the reasons for admission was more people with FTD were admitted because of their behavioral problems, which are common. Again, this is just a graphical representation of that. Destination discharge. We see majority of the patients we are able to send back home, almost 80%. We are able to send them back home. Of course, a few of them we had to send them to a general hospital because their condition deteriorated, physical health problem deteriorated. They had one of them had a myocardial infarction and had to be sent to another hospital. Another patient had a stroke, developed a stroke and had to be transferred to a hospital. So likewise, we had a few patients who had severe physical illness which necessitated transportation to another hospital. So having a good link with the local general hospital is again very important. So in addition to having a network of doctors, physicians who can come to visit your center, having a link with a local general hospital is very important. So a few of them we are able to send them to a care home, about 7%. Again, these are very rare. There are not many care homes which can cater to people with dementia. So look at in Chennai, there are a few coming up who are doing a decent job managing people with dementia, and 3 of the patients died at our center. TS is the TS Santanam Center for Dementia Care. That's where I work. 3 patients passed away at the center. Again, training your staff to managing death, and we provided palliative care for these patients, and how you manage death and how you kind of support the family and support the staff. All this becomes very important. What are the common risks? Staff burnout, retention. That's the top most problem. Regular training, regular skills update, giving a lot of incentives for people working with dementia. So it need not be just financial incentives, even a word of praise. In the patient, neenga nalla paathukitinga, that actually motivates a lot of people. Costs, you need to, as I said earlier, you need to have a good financial planning. Again, you need to be very ethical and practical in where you're going to place, how much you're going to charge the patients, but you cannot function at a loss. Okay. Again, you have a legal, ethical framework, which sometimes is quite complicating, confusing, because you get conflicting advice from different sources. You need to have a system for managing complaints. I mean, this all of us will be familiar. If you're running a hospital, you're going to receive complaints. How are you going to manage that? But a problem will be preventing abuse, because persons with dementia are at high risk of being abused emotionally, physically, even sexually. So thinking about what infrastructure you're going to put in place to prevent that is extremely important. Again, staff sensitization, staff training, reskilling, having frequent meetings with them is extremely important. What are the benefits? Direct benefit to the patients and their families. We have lots of positive feedback from caregivers, lots of positive feedback from families saying that how much it has helped, reducing their levels of distress and improving their quality of life. It remains a training resource for future workforce. We can think of expanding, and this can be a base from which you can expand. And there's lots of opportunities to collaborate and improve. We are right now setting up a tech ward for dementia. So using biosensors and other technology to prevent complications in people with dementia that can be transferred to their homes. These are some of the pictures. This is our activity center at our unit. Again, the same from a different view. Activity, come a dining center. And as you can see, this is a yellow colored toilet door. This is a single room. Having different colors for different doors again helps to a certain extent. This is our dormitory. Again, sorry for the view. It's a panoramic view, so it's all a bit twisted. I couldn't get a better way to show this to you. Again, the lighting is important. With no artificial lights on, how much of natural light comes into the center, having plain curtains, plain linen, all these things designed. So the way it is designed is from any bed in the center, they'll have a direct access, visual access to the toilet. So again, signage, the toilets, these are some of the pictures of patients doing activities in the ward with the staff. Very important. I can't thank enough the colleagues that I work with. They are wonderful. And without these nurses here, we can't run a center. So it's extremely important. Depending on the number of beds you have, you need to have a proportionate number of nurses. So right now we have 20 beds and we have actually 24 nurses. So working in different shifts. So if sometimes when you have a very difficult patient, you may have to have one-on-one nursing to manage that patient, but for a brief period of time before the patient's symptoms are settled. So thank you.